Now, we will be declaring the quiz finale winners. The first prize goes to Dr. Srishant and Dr. Sumi from Government Medical College, Kozhikode. The second prize goes to Dr. Nabita Varghese and Dr. Ambali from St. John's Medical College, Bangalore. Congratulations to you. The next paper award goes to Dr. Shanana Munir. The second prize goes to Dr. Elizabeth. The best poster prize, the first prize goes to Dr. Urmila. The second prize goes to Dr. Ashwini from Amrita School of Medicine, Kochi. Congratulations to all. The prize will be distributed at the validation ceremony, which will be conducted after the academic sessions. Thank you. We now move on to our next session of the afternoon. I invite Dr. Vijish Venugopal, Principal of KMCT Medical College, Secretary of ISA Kerala State. He is a KUHAS PhD guide as well as a KUHAS PG examiner. He has obtained his postgraduate diploma in emergency medicine from George Washington University, USA. His areas of interest include cardiac anesthesia and research. The session will be moderated by Dr. Aruna, Professor of Dr. Mupin's Medical College, Wayanad, and Dr. Ahmed Yaseen.
At the very outset, I would like to thank the organizers for the opportunity to talk on Tiva TCI. Now, this topic was actually not my topic. It was supposed to be given by Dr. Baburaj. Unfortunately, it has come to me. So, what is Tiva TCI? Tiva describes the maintenance of general anesthesia without inhaled hypnotics. And TCI is a technique of administering Tiva using the pharmacokinetic models to maintain a steady plasma or effect site concentration of the anesthetic agents using an infusion device. So, this is how, this is the history. Now, this is a paper published way back in 1980s. And you can see that they said that there was access to circulation, and you can see they have shown accurate fluid administration which was present at that time. And they predicted that there will be in the future pharmacokinetic and pharmacodynamic exactness, and that is what is TCI. So, it was predicted long back. So, the indications as given in the BJA are you have malignant hyperthermia risk, long QT syndrome, history of severe PONV, patients who require a tubeless ENT or non-intubated VAT surgery, patients with anticipated difficult intubation, neurosurgery, myasthenia, and day case surgery, trainee teaching, patient choice. So, we have all been taught how to give anesthesia. It was all by giving inhalational anesthetic. So, we had access to the circulation by using inhalational anesthetics. We had a beautiful vaporizer to give accurate administration, and we could even see the end tidal concentration of the anesthetic, and we could find out the pharmacodynamic exactness. But now we have something called, we access the circulation by having an intravenous access. We can begin propofol or other agents, and the concentration can be measured, and it could either be the plasma concentration or the target concentration. So why Tiva? Now the advantages, or why we give Tiva. There is no mask on the face, there is no smell of volatile agents, there is less pollution of the operating room, there is less emergence phenomenon, there is less PONV, there is no risk of malignant hyperthermia, and you can use this everywhere, not only in your OT, you can use this in the non-operating room, you can use it in the ICUs, you can use for daycare surgery, and there is better cerebral autoregulation. Now, does it have any disadvantages? Of course, you need a IV prior to induction. There is pain on injection. It is irreversible once it's injected. You have a cumulative dosage accumulation. There is need for suitable delivery, drug delivery systems, and there are a lot of plastic waste that is accumulated, the disposables. And there is a risk of bacterial contamination, risk of awareness, and blood concentration is not measured. Actually, there is no measurement. Algorithms are used. Pharmacokinetic models and pharmacodynamic models are there. So the principles of TCI, the first application of TCI was under the BET scheme, that is bolus, elimination and transfer. Here, a bolus was given and it was eliminated and it was transferred to the effect site. So that was the initial concept. But later on, they realized that when a drug bolus is given, it has 3 phases. So then came the 3 compartment model. So you give a bolus, it goes into the central compartment, and from the central compartment can get eliminated, or it can go to the rapidly equilibrating compartment like the skeletal muscle, the skin, and slowly equilibrating compartment like the fat, adipose tissue. And then there will be a equilibration between the central compartment and the effect site, that is the brain. This is the 3 compartment model. Now coming to the choice of agents, the agents which you can use. Now drugs with fast onset and offset times are most useful for balancing adequate hypnosis and analgesia with rapid recovery. And this concept is very important, the context sensitive half time. After you stop an infusion, what is the time for the drug concentration to reduce by 50%? So that is the most important thing, because if it is high, it will impair recovery. So the best agents for this are propofol and remifentanil, because they have very short or minimal context sensitive half life. This is a picture, you can see this is propofol and remifentanil. They have the least CHST. Now coming to the apparatus, now there are 3 key elements of a TCI apparatus we should be very familiar with, that is the manufacturer, the model and the mode. Now the manufacturer creates a TCI device, he will be incorporating a software where there will be a model, it could be the pharmacokinetic model, and recently we have TCI models with pharmacodynamic models, that is a closed loop system. And the models can operate in either mode, either it can operate in the plasma mode or in the effect site mode. That means plasma mode means the plasma concentration, and effect site mode means the concentration in the brain. So a general approach would be that the anesthesiologist is the person who is going to set and adjust the dose concentration, but he does it if he has a prior knowledge of the dose concentration and effect. He gets an electronic feedback from the pharmacokinetic simulation or from the pharmacodynamic effects, like if you monitor the process DEG, you know what is happening. And of course, the most important one is the clinical feedback. So I had mentioned about plasma target and effect site target. So in plasma target, the plasma concentration, it never overshoots. You set it at 3 microgram per ml for your propofol, it will slowly, the concentration will rise to 3 micrograms per ml after a bolus and an infusion. So you don't have to do any mathematical calculation, because since we are all doctors, we are very poor in mathematics, the machine will take care of everything. So you just have to enter the values. Similarly, the effect site concentration, it is going to predict what to, you put in a value of 3 microgram per ml, it will predict, there will be a there will be a bolus and an infusion given to reach that level in the brain. There is no measurement, it is only a prediction. So, to be more, you have 3 Tiva practice domains. You can have manual control, you can have an open loop control and a closed loop control. So, manual control is you use a routine pump and you give the drug. So, this is the dose domain, is very simple and is familiar to all, but it ignores the temporal changes. This is the first model that was developed, that is the Bristol model, or what we know as the Price-Roberts model, and it is based on 3 compartments, and it says that if you give propofol in a dose of induction dose of 1 milligram per kilogram, and if you follow it by a maintenance of 10 milligram per kilogram per hour for 10 minutes, 8 milligram per kilogram for next 10 minutes, and 6 milligram per kilogram per hour for continuously after that, you will achieve a target plasma concentration of 3 microgram per ml, which is the needed one. So, this is just a assumption. The next model is the concentration domain. Here what happens is you have a TCI pump and there is a pharmacokinetic simulation on the pump. So, this will automate the dosage calculations and it accounts for temporal changes and it is quick to steady state. And finally, you have the effect domain, and here you need an effect monitor to monitor what is happening in the brain. It could be a process EEG or a BIS monitor, and that is also reflected back onto the pump. So, these are the 3 available modalities: the manual control, the open loop control and the closed loop. So, each has an extra addition. The first one has only a standard monitor, the second one has a pharmacokinetic simulation, the third one has an effect monitor too. So, this is just like surfing. If you look at that curve there, you can see that it is just like a wave that is coming on to you. You can see this wave if you look at the pointer. So, this is just like a wave that is coming towards you, the effect concentration, and as an anesthesiologist, it is a duty to surf along the crest of the wave. If you go below, you will drown. So, it is very important that you stay at the crest. So, how can you do that? You can do it by looking at the pharmacokinetics, the pharmaceutics and the dynamics. Now, if you go beyond the crest, there is no effect. If you increase the concentration, it just increases the side effects. So, you can use 3 domains. You can use the kinetic domain. You can set your dosage accordingly and you tend to stay here, so that even minimal changes you can have different effects on the effect, and you can use your dynamic changes in the EEG or the BIS monitor to adjust the dynamics. And similarly, pharmaceutics, this third domain is deciding which drug that you will use. Ideally, we will be using mainly 2 drugs, that is propofol and remifentanil. There are a lot of models available. These are all algorithms that are inbuilt in the machine. For propofol, you have Marsh, Snyder, Eleveld, Kataria, Pedfuser. So, this Eleveld is known as the universal model because you can give from an age of 0.5 years to 88 years, whereas the other models are to be used in adults. Similarly, the Kataria and the Pedfuser are used for pediatric patients. Many other drugs can be given and there are algorithms for that. So, this is beyond the scope of discussion today in view of time. So, the most commonly used drugs are propofol and remifentanil, and these are the values we have to remember. The effector site target concentration on induction for propofol is 4 to 6 microgram per ml, and if you use opioids, it is 3 to 6. Remifentanil you use around 5 nanograms per ml. Now, this was introduced in 1990, intravenous propofol anesthesia using a computerized infusion system by White and Kenny. And if you look at the history, you can see the pumps were so huge and large, and presently we have pumps which we can carry to different places. And if you look at the TCI, which is a mature technology, you can see it is available all over India, but which continent does not use it? It is not FDA approved for usage in the United States. And if you look at the patient characteristics as per the NAP7, that is the National Audit Project 7 in UK, you can see that the Tiva use has increased from 8% to 26%, and the use of processed EEG has increased from 3% to 19%. So, there is an increase in the usage of total intravenous anesthesia, and we all know that the inhalation agents are creating a lot of problems with the ozone layer as well as the greenhouse effect, because it is just like driving your vehicle for almost 100 kilometers if you use 1 hour of sevoflurane. It is driving to 1000 kilometers if you use 1 hour of isoflurane. So, all this is going to cause problems for the greenhouse effect, and Tiva became very popular during the COVID pandemic. Now, there are certain tips and tricks that we should know. You have to infuse close and secure to the IV line. You should keep the IV line always visible, because you have to note whether there are any disconnections. You should be alert for infusion disruption. So, you should always look at the IV line, whether it is kinked, whether it is flowing, because otherwise the effect will not be maintained. And always load the pump and then program the machine, so that that error also can be minimized. Always consider using EEG because of the risk of awareness, EEG or BIS or entropy. Check the infusions very frequently whether they are flowing. So, always be inside the theatre, do not roam around after giving TCI, and always consider a real time PKPD simulation which is there on the machine, and adjust your dose for your elderly patients, because they require a lower dose. And again, for obese patients also you should adjust the pump weight setting. And deepen anesthesia with, suppose you find that the patient is moving, you have to deepen anesthesia with small bolus and infusion rate increase. So, the mnemonic to remember is, this is a mnemonic in NHS, press to start Tiva. You will be using propofol, remifentanil, you should have EEG and your pump should be adequately charged, the setup should be ready, and the settings we should identify the correct drug, and you can start Tiva. So, there is a fight going on between the two proponents, whether Tiva is better or the inhalation anesthetic is better. Now, this is a study which was published in 2024, and this is from the Journal of Cardiovascular Medicine, and they found that absolutely no difference between either Tiva or inhalation anesthetics. But this was a study which looked at the postoperative complications after colorectal cancer surgery, and they found that the surgical complications were higher in the inhalational group, whereas the medical complications were higher in the Tiva group. But when the confounders and the 30-day mortality was again higher in the Tiva group. But when the confounders were removed, the mortality was the same. Another study again published in 2024, where they found that the secondary outcomes like postoperative pulmonary complications, perioperative adverse cardiovascular effects, and acute kidney injury was higher in the inhalational group. So, what are the future directions? Should we restrict Tiva in the theatre? Well, it can be used outside the theatre for adequate analgo sedation, like you can use the pump for patient controlled analgesia using hydromorphone. This was done in post cardiac surgery patients, and similarly it can be used in the intensive care for providing postoperative pain. Also, our patients in the ICU undergo a lot of clinical procedures, like you might have a patient who is not tolerating the non-invasive ventilation. You can put him on a target controlled infusion for propofol, so that he will tolerate the NIV. Also, fiber optic bronchoscopy can be done using TCI with propofol and remifentanil. And certain alternatives have been identified for remifentanil, like magnesium, lidocaine. All this can be used as an alternative and can be used in the TCI pump. Also, there has been a development of a closed loop system for vasopressor infusion post cardiac surgery using the TCI pump, where they found that the total dose of norepinephrine which was infused was much lesser when a closed loop system was used. Also nowadays, the again bispectral index and so many closed loop systems are coming into being. Also, people have started using TCI pump for delivering antibiotics like the piperacillin and vancomycin. So, coming to the pro con, if you look at the pro side, those who are in favor of Tiva, they say that there is a lot of clinical advantages. There is less post-operative nausea, vomiting, there is higher patient satisfaction. And also you have safety and environmental impact. So, they all say that Tiva is better. But looking at the con side, organ protection is supposed to be better, especially in conditions where ischemia reperfusion injury is there, which is in favor of volatile anesthetics. But if you look at it properly, Tiva is not so environmental friendly because you have to use a lot of plastic waste. You will be generating the syringes, all this have a life cycle assessment. So, there is a lot of plastic waste generated by Tiva because you are using syringe pump, infusion pumps, so infusion lines, all these are waste. So, both are actually harmful, but ultimately the Tiva proponents are winning, saying that we are better. But you should have a balanced viewpoint because you should look at your patient comorbidities, the surgical context, the resource availability and institutional preferences to decide which is better. You have a lot of mobile applications for giving Tiva, that is the Tiva TCI simulator, you can download it on your mobile, or the Tiva manager. There are a lot of potential problems with Tiva like awareness. This was not because of Tiva as such, it is because of the improper education and training of the anesthesiologist. The anesthesiologist was at fault, not the Tiva machine. And especially in remifentanil, you should consider giving a transition opioid like fentanyl before you stop the infusion. And there are some reports of propofol related infusion syndrome. And this is a beautiful guideline that is available for free download. This is by Nemo and colleagues for how to use Tiva. So, they specifically say that you should have something like an anti-reflux valve and anti-siphon valves where you give these drugs. There are a lot of consensus statements. So, the dilemma is even now we really truly do not know which we should use, which is best for our patients. So, there are so many trials that are going on. One trial is the Thrive trial, which is done in US. There is another trial called the Vitals trial, which is done in the UK, and there is a third trial, the Vapor C trial in Australia. Results we are expecting in 26, 27 and 29. Then probably we will be able to decide which is better. So, summarizing, TCI technology is recent yet invaluable addition to the anesthetist armamentarium. A comprehensive understanding of the 3-compartment model is essential. Majority of the drug models in common use, they lack generalizability. The LLL model is considered as the universal PKPD model. Similar model like the Honeywood model has been developed for giving dexmedetomidine. So, besides the newer modes of drug infusion, TCI technology itself has undergone significant evolution. The incorporation of TCI into ICU has resulted in better NIV tolerance, improved patient cooperation during clinical procedures like bronchoscopy, cost-effective antibiotic usage and superior postoperative analgesia. Now, as the environmental concerns of inhaled anesthetic agents mount, it can be hoped that TCI technology will permeate further into anesthetic practice and will be ubiquitously used in days to come. Thank you.
Thank you, Dr. Vijish. It was a very elaborate, detailed information regarding Tiva. Actually, it's more important for us in ICU setups here. We are managing, I think, dexmedetomidine infusions techniques over here, intravenous. Actually, way back in 1988-89, when I was doing MDA, we were following some IV techniques with thiopentone for OPD patients for close reduction of fractures. Just imagine we were doing with all risks and keeping the mask on the patient, and we were giving intravenous. Of course, IV line would be there. We would take a IV line and fix it up, and then we would give thiopentone 3 to 5 milligrams per kg till the sedation and the palpable reflex is gone. And that moment that the orthopedic surgeon would be ready and he would just reduce the fracture and then we would cut off the IV. So that was a technique we used to follow then. And now the Tiva has come into effect with propofol and remifentanil. So these are better methods, and I think infusion techniques can have titrated doses that can help patient post-operatively than intraoperative setups where surgical different types of surgical procedures are there. So
nowadays they are promoting the non-operating room usage of Tiva.
Yeah. Non-operating room, it's better, I think, controlled with the infusion techniques. And also, I think their safety measures have to be there, or backup has to be there, wherever we are using Tiva, because once it's gone IV, it's
so they
not
say that if you are using muscle relaxants, it's always better to have a monitoring of the EEG, the processed EEG or the BIS or entropy, if you are using muscle relaxants. So that is the recommendation they have given in those. That recommendation, due to lack of time, I didn't read it out.
Yeah. Thank you so much. And session is open for discussion if anybody wants to talk. Thank you, sir. Thank you so much.
Thank you, sir. Thank you, ma'am. Now I request Dr. Aruna to please come to the stage to felicitate Dr. Vijish. Now, I request Dr. Rajesh to please come to the stage to felicitate Dr. Aruna and Dr. Ahmed Yaseen.